Hi, everybody. It is great to see everybody on the call today. So, we're just going to hop right in. We have a lot to cover today. And so, first, let me see, make sure I get my stuff all working here. Okay. So, the Missouri Rural Health Association, I was hired back in May of 2023 to kind of revitalize the organization and to help us move forward on a new approach for how we are engaging with the state. So, the board decided that they wanted to move away from being a programmatic organization to one that works more at the 30,000 foot view to create a stronger rural health community in Missouri. So we have been developed a new strategic plan, and our focus is going to be in three areas. So advocacy and policy, education and training, and convening and connecting. So today, obviously, we are going to be starting with our advocacy and policy and giving you guys some updates about what's going on at the Missouri Capitol. So there's a really old adage that if you're not at the table, you're on the menu. And this is very, very true when it comes to money and support from both DC and Jefferson City. There is so much opportunity to get involved with policy work, and we want these calls to be able to educate and inform our rural partners and to help you feel comfortable to get more involved at the Missouri Capitol. So today we're going to give you a brief high-level overview of kind of what's going on right now. We're still in the very beginning of session, so just kind of give you a lay of the land about what the House and the Senate looked like, an overview of our legislative priorities, help you find your legislators if you don't know who they are. And then each month, we are going to highlight certain bills to give you guys some more information. So I'm just looking to see if our partner is going to be on and who will be talking about our 340B bill. So the first thing I wanted to start with is give you a rundown of what our legislature looks like currently. So, as you know, we have two houses in the Missouri General Assembly. We have first the House of Representatives. It's considered the lower chamber. It has 163 members representing districts with an average of 37,000 residents. House members are elected for 2-year terms during general elections held in even number years. And Missouri's House is the fourth largest in the United States, even as the state ranks 18th in population. There's not over 100. So 18th in population. So this is, you'll see here that there are currently 110 Republicans and 52 Democrats, and we have one vacant seat. There was a Republican legislator who took on he took on a new role and decided to resign his position from the Missouri House. He was entering into his last term anyway, so they will be looking to fill that at some point. But you'll notice that we also have a supermajority of Republicans in the House. The Missouri Senate is the upper chamber of the Missouri General Assembly. It has 34 members representing districts with an average population of 181,000. And its members serve 4-year terms, with half of the seats being up for election every 2 years. So again, this last election in 2024, we had half of these seats that were up. The Senate then chooses a president pro tem to serve in the absence of the lieutenant governor, or when he or she shall have to exercise the office of the governor of Missouri if there's a vacancy in that office due to death, resignation, impeachment, or incapacitation. We currently, our current president pro tem, she is our first female president pro tem of the Missouri Senate ever. So Cindy O'Loughlin, she is wonderful to work with. She is very level-headed and is easy to work with. And so we are very excited that she is now leading the Missouri Senate. Members of the Missouri General Assembly are prohibited from serving more than 8 years in either the State House of Representatives or the State Senate, or a total of 16 years, and that is due to statutory term limits. So those went into effect. It's been over a decade now that those have been into effect, and so we really saw the makeup of the Missouri General Assembly after that happened. And at the start of the 2025 session, Missouri was one of only 20 state legislatures where Republicans had a veto-proof supermajority in both chambers, or is a trifecta because it's the Senate, the House, as well as the governor's office are all controlled by the Republican Party. So that really puts our Democrats here in the state of Missouri in an oppositional role to try to stop a lot of legislation that goes through. So, by a show of hands, I guess, using your information, if you could go ahead and just raise your hand and let me know if you know who your legislators are. So just go ahead. So I'm seeing a couple hands here. Good. All right. So just a few. So there may be some folks on this call who don't know who their legislators are. So I'm going to show you here real quick on how you can find them. So if you go to the Missouri House of Representatives website, which is house.mo.gov, it should look something like this. So it kind of adjusts to your screen, but you're going to want to find the place where it says find your representative. You need to put in your street address and your city. And what should happen after you put that up is that you will get a screen that looks like this. So these are my representative and senator. So these are our state legislative officials. So for me, I live in Callaway County in central Missouri. So my representative is Jim Schulte, and my senator is Travis Fitzwater. And then if you continue to scroll down, you'll get information on all of the other statewide elected officials. And then further down, you'll see who your federal representatives are as well. But for the purpose of the discussion today, you'll want to know who your state legislative officials are. So who is your state rep and who is your state senator. So then what you can do is if you click on them, so you'll see it's blue there. If you click on it, it will take you to your legislators page. So this is my representative, Jim Schulte. You'll see his District 49 when he was first elected in 2022. So this is his second term in office, and he's so far served 3 years. He's from New Bloomfield, and he covers Callaway. And so you get a little map here of where they're at, a biography of the legislator, any current bills that they are sponsoring. So you can take a look at these, see if any of them are of interest to you. What their address is in the Capitol is here. So you'll want to pay particular attention to the room number. So he is in room 405A. And then you really want to look at what committees that your legislator is assigned to. So Representative Schulte, he is in Crime and Public Safety, where he's the vice chair. Veterans and Armed Forces, where he's also the vice chair, and Utilities. So this comes into play whenever you're looking at certain committees that tend to be really more in depth with the healthcare community that we're looking at. So those are going to be things like if your representative is on health and senior services or is on insurance, that we have a hearing on that coming up this week. And so I'll point that out to you here shortly. Or professional registration is another one that we sometimes get folks. Emerging issues. So if your legislator sits on any of those committees, that is a good thing to keep an eye on because they're going to have more power within the process for the bills that we're talking about. Okay, so I want to go over a little bit, just give you a 2025 legislative overview. So session just started on January 8th and will go through May 16th, and bills can be filed until March 1st. As of last week, I should have updated the numbers for today, but as of last week, in the Senate, there are so far 607 bills, and in the House, there is a total of 1,017. So I know there have been more bills introduced this past week, so that number, I'm sure, has gone up. So in 2024, so just to give you kind of an idea of what happened during last session, so you could get kind of an idea of what might happen this session. So 2024 I say that 2024 was actually a very unusual year. We say that it was an unusual year. However, we've been having a lot of unusual years, particularly since COVID. But only 46 bills crossed the finish line and were sent to then Governor Parson for consideration. And those were 18 appropriation acts, 2 joint resolutions, 15 Senate bills, and 11 House bills. And in the end, only 28 non-budget bills found success. That's fewer than the previous low water mark set in 2020, when only 31 bills passed because the legislative session was upended by the COVID-19 pandemic. We were actually out for about 6 weeks in the middle during 2020, which is why so few bills were passed. But last year, we beat that number. Yay, go. And we only had 48 bills cross the finish line last year. And so that was for a number of reasons, everything from it being an election year so there was a lot of competition to get the word out on yourself in case you were interested in higher office or moving into a different position. And then also part of that was a lot of political infighting that was going on at the Capitol. There was a lot of fighting over in the Senate with the majority party. And so that really slowed down the works last year. We're hoping that this year, because of the election, we had a massive changeover in 2025. Because of the 2024 election, we have a new governor. We have all new, except for one state office holders, and big changes in the Senate and the House. So we're really starting over, and we're hoping that with the new leadership, it will be a more civil environment and more productive for 2025. So at MRHA, the Advocacy Committee and then the Board of Directors approved the following policy agenda for 2025. These are areas that we're focusing on in all of our legislative work throughout the year. So these could potentially change from year to year, but for the most part, these are the areas that will most likely stay the same, but the bills that we'll be talking about under each of them will change. So what our agenda this year is investing in rural health infrastructure, providing stabilizing relief for rural providers across the state, including but not limited to critical access hospitals, federally qualified health centers, rural health clinics, and rural hospitals. Investing in a strong rural health infrastructure is critical to the future of rural areas. Our second area is reducing rural healthcare workforce shortages. So supporting rural communities in seeking to recruit, train, and retain healthcare professionals. And lastly, addressing rural declining health expectancy and access to care. Addressing rural health disparities through ensuring access to healthcare, investing in public health, and prioritizing chronic disease prevention and OB support. You will find all of the bills that we are tracking on the MRHA website. So you'll see here, if you go to mrhassociation.org, click across the top with advocacy and policy, and it'll take us to our bill tracker. So you'll see here, this is the bill tracker. I took this last week. So you'll see that this bill, SB 45, it was on the calendar. You'll be able to scroll down to see all of the bills that we're tracking and be able to follow along if there's anything of particular interest to you on those. So this year, our board has approved us following a number of bills. So I wanted to do a little bit of information on a few of these and highlight 2 in particular that do have hearings coming up this week. So the first is 340B and pharmacy services. I'm going to hold on this one because our guest speaker is going to be speaking more in depth about the 340B program. They did have a hearing for SB 13 and SB 45 last week. They're expecting that to be, I believe they're expecting that to be voted on this week during committee. But our consultant that we're going to be working with, she is going to provide some more information in depth about the 340B program here in a minute. The other bill that we're working on this session is prior authorization. So this bill, we have a hearing on that this week coming up. So House Bill 618, And it has a hearing on Monday at 1 o'clock in the insurance committee. So if there is anybody on this call that has an interest in prior authorization and getting this passed this year, please let me know, and we can hook you up to go to the Capitol on Monday to offer testimony. This will probably be a pretty crowded hearing on Monday. And so just expect to keep your testimony short, but if you are wanting to listen along as well, I'll give you some more information at the end on how you'll be able to do that at the very end of this call. Another bill that we're keeping a close eye on is audio only telehealth. This is HB 825, Melanie Stinnett. This bill is very straightforward. It adjusts the definition of telehealth services to include audiovisual and audio only technologies. We're working with a number of partners on this bill, and this bill does have a hearing this week as well. It is going to be on Tuesday at noon. So if you are interested in coming and testifying on that bill, please let us know that as well, and we will give you all the information on that, and I'll show you how to find that again at the end of this call. The next bill we're working on is annual supply of birth control. This legislation is Senate Bill 178 and House Bill 398. And so the private insurance plans in Missouri only allow for a 30 to 90-day supply of contraceptive at a time. This is in conflict with provider practice, public health recommendations, and national policy trends. So limiting the supply of contraceptives to these short interviews reduces timely access, creates gaps in use, and increases the likelihood of unintended pregnancy. This legislation would provide an option to acquire a year-long supply of birth control at one time, rather than forcing people to return to the pharmacy every month or few months to refill. This bill is particularly beneficial to individuals living in rural areas. Almost 375,000 Missouri women live in contraceptive deserts or counties where there's no reasonable access to a health center offering a full range of contraceptive methods. Of those 375,000, roughly about 65,000 women live in counties without a single health center that offers the full range of contraceptive methods. So these women face additional transportation costs, childcare costs, and unpaid time off because of the long distances they need to travel to access care or pick up their prescriptions. This bill made it very, very close to the finish line last year. It was added into a wide-ranging women's health bill that was victim of the Senate gridlock last year and died with one vote left at the end of the session. It has received a lot of media attention. There was recently an article in the St. Louis Post-Dispatch about the legislation, as well as information last year. The Jefferson City News Tribune ran an article about this last year that included some excellent quotes from your favorite Rural Health Association executive. And so we are keeping a close eye on this year. We expect that the bill will probably be added on to a number of other places near the end of the session. And then the last bill that we want to bring up today, and we'll have more information on all of these on further calls, is a Patients First Act. This is provider non-discrimination, and these are HB 530, HB 309, and SB 499. And that's included in the Public Health Services Act, which passed in 2010. It established federal non-discrimination protections for providers. This provision is important for patient safeguard aimed at ensuring access to needed care and an ability to seek care from the provider of their choice. The Section 2706 prohibits group health plans and health insurances offering group or individual health insurance coverage from discriminating with respect to participation and reimbursement. So this bill, it's being supported by a number of organizations, but basically it's requiring reimbursement to be the same as long as you meet scope of practice. For example, nurse anesthetists in the state, they had been, up until this point, reimbursed at the same level as our physicians. The name just went out of my head. Anesthesiologists. There we go. So it's Friday. It's been a long week. Our anesthesiologists, they were paid at the same level through insurance. Unfortunately, several of the health insurance companies have started lowering the amount that they're offering for those providers. They're deducting about 10, sometimes 15% from what they were reimbursing in the past. So this is obviously a problem for a lot of our smaller rural hospitals and folks who are offering anesthesia care. They had been able to bill at a higher rate. Now they are no longer able to do so. So we already know that a lot of them are struggling with reimbursements as it is, and this just provides another hindrance to being able to be fairly reimbursed. And so we're keeping a close eye on that bill as well, and are working with a number of partner agencies. So I'm going to stop sharing screen for a moment, and I am going to turn this over to our special guest today. Let's see. Go ahead.
I'm right here.
Oh, there she is, Colleen. All right, go ahead, Colleen. So if you have something to share, you're welcome to share your screen.
Absolutely. That would be great. Hold on just one second here. And just let me know how long, how are we doing on the calendar?
15 to 20 minutes.
Okay, perfect. Okay. Hold on one second here. Just till I hit share. Okay, can you see that all right?
Sure can. Looks great.
Great. Okay. Well, I'm very honored to be here with you guys today. Hold on, I'm just setting my timer so I don't lose track of time here. But I work directly with the Missouri Primary Care Association, so with community health centers, FQHCs, be them urban or rural. Although I will say that my grandmother is from Potosi, so I have rural Missouri roots. So she's a Portel. If anybody from that part of the world knows, Portel is a pretty popular name down in that part of the world. So I have been asked to speak today specifically about the 340B drug discount program. And if you have managed to get this far in your life and not had to learn anything about 340B, I would say count your blessings. Not all of us have been so lucky, but what I'm going to discuss today is some program basics. In particular, how the program generates savings. And then I want to talk about how PBMs, pharmaceutical benefit manufacturers, are getting our savings, are taking these savings away from the safety net, and how various states are responding. So, just some basics of the 340B program. The name comes from the section of the Public Health Service Act. I joke for years that it's been the loosest written statute I've ever encountered in health policy. Doesn't even have a name. Okay, but this section of the law requires drug manufacturers to sell drugs at discounted rates to certain safety net providers. And just to be clear, it's an outpatient only program. Okay. Drug makers have to agree to this if they want to get their drugs covered by Medicare and Medicaid. Okay. So they're not voluntarily offering up these discounts. They are doing them because they have to do it if they want to be in Medicare and Medicaid. Also, I would point out that these discounts, therefore, are entirely funded by drug makers. There is no taxpayer cost associated with this, other than the tiny cost of the agency that oversees the program. I mentioned that certain categories of safety net providers are the ones who are eligible. About 85% of the 340B program is hospitals, particularly hospitals with a disproportionate Medicare disproportionate share percentage of 11.75 or above. But for you guys, I would think critical access and sole community hospitals are the ones in rural areas that are most for whom 340B is often lifeline. About 15% of the program is for what we call federal grantees, small organizations that get federal grants. So community health centers, also known as FQHCs, are one of those. Ryan White clinics, AIDS drug assistance programs, and then a lot of little groups like family planning, grantees, hemophilia, that sort of stuff are all in there. Okay. So one question I get a lot is, well, so you're getting a discount off of the sticker price. How big is the discount? Well, the only discount we're guaranteed to get is what I call just, the required discount. For a brand name drug, it's 23.1%. For a generic drug, it is 13.1%. But the reality is, in recent years, although it's been slowing down a lot, we've been getting discounts that are a lot bigger. And the reason is, when Congress created the program, they were worried about how quickly manufacturers are raising drug prices. And so they said, we have to find a way to penalize them for raising drug prices. So, and by the way, this is the same formula that's used for calculating Medicaid rebates. So the formula Congress put in place said, well, there's a mandatory 23 or 13% discount. But if a manufacturer raises a drug's price faster than inflation, then we're going to turn around and make them pay a larger discount over on 340B and Medicaid. So because of that, a lot of drugs end up being a much bigger discount. Some of them, not as many as there used to be, but some of them get down to like a penny price because the manufacturer has raised the price so fast. And then the discount gets to be so big. So when drug makers complain about the size of the discount, I always say to them, well, if you weren't raising prices so fast, you'd only be paying like 13%. So my sympathy is a little bit limited. As to why 340B was created in the first place, there were a lot of it was sort of an outgrowth of the Medicaid drug rebate program. But as little community-based providers like community health centers, we don't have the market power to go negotiate with Merck or Johnson and Johnson or Pfizer to get discounts. We were stuck paying the sticker price, okay? Whereas the big for-profit groups, whether it's a large health system or a large PBM, they can all negotiate all those discounts. And here we are, the smallest group of people caring, or the smallest providers caring for the most vulnerable people, and we're paying sticker price. So that is why Congress came in and said, no, these guys deserve a discount regardless of how small they are because of the important role that they're playing in the safety net. And actually, before 340B, almost no health centers even provided drugs because we just couldn't afford them at the regular price. So Congress created the program, and they said specifically the intent is, or we want to permit these 340B providers to stretch scarce federal resources as far as possible, and so that they can reach more patients and provide more services. So 2 points I want to make about that program intent. First of all, Congress intended for 340B to directly support safety net providers, not necessarily individual patients, and relevant to this discussion, not for-profit PBMs, pharmaceutical benefit manufacturers, okay? Patients do benefit, but they might benefit because there's another doctor on staff or because we have a whole different type of service that we can provide. And I'll get to that in a minute. But the other thing I wanted to say is that 340B, yes, it's a drug discount program, but by freeing up funds, and I'll get to how that happens in a minute, 340B makes it possible for community health centers, critical access hospitals, et cetera. It frees up the funds they need to support a whole bunch of other services. So it's about way more than pharmaceuticals. Oops, sorry, hit that the wrong way. Okay. And 340B grantees, at least, now not the hospitals, we are required by law and by regulation to take every penny of our 340B savings and invest it right back into services that expand care for our medically underserved populations, for our patients, okay? So for your average health center, 340B generally supports care for uninsured or underinsured patients. If we very often it's for dental care, it's for school-based primary care, it's for transportation, it's for vision services, it's for behavioral health. It's done a lot to deal with a lot of the counseling around substance use disorder and whatever at health centers has been funded through 340B. Okay. It varies from health center to health center because our health centers are community-based and they decide what is the greatest need of their community. And that's where they decide to put the funds to come from 340B. So just to be clear, 340B is not just a nice little add-on. It is essential to the financial stability of a lot of safety net providers. Like for community health centers, it varies by health center. But for a lot of them, it's bigger than their federal grant. A lot of critical access hospitals nowadays say that their doors would close if 340B is taken away. And they're struggling even more than they have been now because of a lot of the restrictions being placed on 340B. So it is not an overstatement to say that without 340B, a lot of these providers simply would be closing up their doors. So want to get into the mechanics here for a minute of exactly how 340B generates savings, because to understand where PBMs come into this is necessary. This is it's actually a two-part spreadsheet or a flow chart, but it just was easier to read this way. So let's take an example. Start at the box number one way up top. Let's say you take a drug where the sticker price is $100 and the 340B discount is $30. There was a required discount and then there was an additional discount because the price dropped faster than inflation. Okay. That drug is then shipped to either a contract pharmacy or a pharmacy that the 340B provider owns. That's kind of where it gets shipped is not necessarily relevant to this conversation. But the point is that we paid $70 for that drug where the regular price is $100. Now, let's go down the left-hand side to start with. Let's say we have an insured patient. Okay. The way this program was designed, that insured patient is supposed to pay us $100. And we paid $30 for the drug, right? So we sell it to the insured patient. The insurance company pays us $100 and we come out $30 ahead. Okay? Because of the difference between what we paid and what insurance pays. But now let's go over here to box number 6. We also have a lot of uninsured patients and a lot of underinsured patients, being patients whose deductibles are so high they might as well be uninsured. Okay. So one of those patients comes in and we know, because we charge everybody on a sliding fee scale, that person qualifies to pay no more than $20. Okay. So that person pays $20 for the drug that we paid $50 for or $70 for. We're short $50. So this is just simplified example. Let's say the health center dispenses this drug to 3 patients who have insurance. 3 patients, that produces $90 in savings. What do they do with that $90 in savings? Well, they take the first $50 of it and they use it to make up for the loss on making the drug affordable to an uninsured or underinsured patient. And then they have $40 left. And that $40 left goes to whatever that community has decided is its greatest health needs, substance abuse treatment, dental care, whatever it is. Does that all make sense so far? Great. Okay. So the reason I went through all of that is 340B has been around since 1992. It's been around for 32, going on 33 years now. Okay. It is essential to the financial stability of critical access hospitals, community health centers, a lot of others. And then around 10, 15 years ago, this new type of organization started popping up called PBMs, right? Pharmaceutical benefit managers. Very clearly for-profit organizations. 90% of the market is controlled by 3 big companies. Okay. And they figured out how to get those 340B savings for themselves. Remember how I mentioned the statute wasn't written very tightly? I've always said you want a statute that's written like a steel trap, and 340B was written kind of like a fishing net. Well, 340B statute said we intend for these savings to go to the safety net providers, but they didn't put a kind of cap on the cookie jar. They didn't make sure that they could keep them. And PBMs discovered that. And so they started saying, hey, wait a second, you're a 340B provider. You only paid $70 for that drug. Everybody else paid $100. We're only going to pay you $70 for that. So we get that $30 savings ourselves. Okay. And they found other ways to discourage. There's many, many ways they have figured out how to take the savings for themselves. That just paying less is the simplest example. But they've also found ways to discourage 340B providers from discourage patients from going to 340B providers at all. They'll keep 340B providers out of their preferred networks. They'll run up the copays on 340B providers. The reason they do that, and the reason they say they're justified in doing that is, a recent development is that manufacturers now pay these big rebates back on a lot of drugs to the PBMs as a way of trying to increase their market share. Hey, Merck will say to, say, Caremark at PBM, hey, Caremark, if you put our drug on a preferred list so we sell more, we'll give you 40% back of the money we make. I'm sure you've seen this whole dynamic play out. There's a lot of negative consequences coming out of that dynamic. But one of them is all those rebates that they get back from the manufacturers, they can't get them on 340B drugs. So they're like, oh, well, we can't let the health center get that savings if it means that we're not getting our rebate back from the manufacturer. So they find other sorts of ways to block us. So Congress has been trying to deal with this for years. There's a bill out there called the 340B Protect Act, that the Protect 340B Act, that would block this type of discrimination on a national basis. Unfortunately, there are other issues around 340B that I'm not going to get into right now. And the thought in Congress is, the quote I always hear is, you pull the string, you get the sweater. If you start trying to deal with PBMs taking our funding, suddenly you're in the midst of all these other issues. Okay. And then people get overwhelmed and they just say, we're not going to do anything about it. So, in classic American style, the states have been stepping in where Congress fears to tread. And to date, over 30 states, I think it's 34, have passed laws banning PBM discrimination in 340B. They have said, look, that money, those savings were meant to go to the safety net providers to keep their doors open and their patients cared for. They were not supposed to go to the PBMs. Okay. Missouri is not one of those states. You have gotten a 340B PBM bill passed one of your legislative chambers, I don't know, 2 years ago or something. But as you can see, you're one of the ones who is left who has not yet passed this bill. And so that's one of the bills that I know people wanted to talk about today. So with that was my very quick and dirty overview of 340B. Do you have any questions? I mean, I could talk about this for hours, but I think you'd prefer I don't.
Feel free to come off mute if you have any questions, or you can put your question into the chat. This is a very complicated topic. And so, with this bill moving during session, as already had a hearing, we thought it would be good to get some more information out to folks who might not necessarily know all of the ins and outs.
Well, and can I say something that's unusual about Missouri? There's another type of state law out there around 340B, one around contract pharmacies. The PBM stuff has been considered pretty common sense. I mean, that's why so many states have done it. You've done the much harder thing. You've done the contract pharmacy stuff already. It's sort of funny that you haven't done the easy thing. Every other state I know has done it the opposite direction. They've started with PBMs and then moved into. So it's rather interesting that you haven't done the easier thing on 340B.
Colleen, I have a question.
Okay.
And this is more for the benefit of the group, actually. But once again, I mean, to your point, we should have been able to pass this by now. The insurance lobby is tenacious. And so what we're discovering again this year with this legislation, insurance is up against it again, but also the carpenters union. There's a little bit more to it than that. It's a little more nuanced with regards to who represents the carpenters union, and that's kind of why they're weighing in. However, the labor union as a whole has taken some interest in this year and is interested in opposing it. Do you have any idea, or can you speak to that to the group as to why the labor union might oppose this legislation?
Absolutely. Believe me, the labor unions and the carpenter unions, I'm surprised you haven't said Anheuser-Busch, the big employers in your state. The manufacturers, the drug manufacturers like to go out and gin those groups up. The PBMs, excuse me. The PBMs like to go out and gin up groups because self-insured groups. And this is their argument. If we're having to pay that health center $100 instead of $70, your prices are going to go up, and we'd be able to charge you less for drugs if we didn't have to pay them. Okay. My response back to that is, first of all, prove to me that any of those savings are actually passing through to real patients. Okay. I just can't see that. it's one thing they do this in every state. They like this in Maryland, where I'm from. It was Under Armour. It was our big thing. Oh, Under Armour patients' costs are going to go up if you make us do this. PBMs have got to be, along with drug manufacturers, the most opaque organizations out there. I have no comfort whatsoever that when they say that if they keep these savings, they're going to drop prices for patients, that's actually going to happen. Excuse me, is number one. Number two, this program, 340B, has been around and been an established part of funding the safety net for over 3 decades. Just because PBMs realized that Congress made a mistake and didn't put a lid on the cookie jar, so to speak, and they realized that within the last 8 to 10 years, does not suddenly entitle them to come in and disrupt something that is critical to the functioning of the safety net. So those are my responses.
Thank you.
Mm-hmm.
Any other questions? Okay, if you have any, feel free to hop into the chat. I'm going to go back and share my screen again. Thank you so much, Colleen. That was
Absolutely.
a great presentation. We really appreciate it. You made something that's quite complicated sound quite simple. So we all know that's not the case. So I wanted to share with folks how you can look up these bills and find the actual language, and also find information on the committees. So we're going to start with SB 13. So SB 13, and you'll notice, so SB stands for Senate Bill, HB stands for House Bill, and that's where the bills originate. So here is the Missouri Senate website. You can type into the bill search. I'm doing Senate Bill 13. So Senate Bill 13 is the one that was heard last week around this program. And so pop it in, it'll pull up the record, click on it, and you will come to a screen that gives you a bill summary. So this is everything that is in that particular bill in a summary format. You can see full bill text if you click there, and it will open up a PDF that has the full bill text. This bill's only 6 pages long. That's pretty good. We have some are shorter, but we do have a lot that are far larger than that come through. So if you wanted to read the actual bill text, you can do that there. You can see who the sponsor of the bill is. If you click on that, it takes you to their website. Same thing with what committee that it's being heard in, and you can see the committee makeup. So I thought the reason I wanted to show you this is to make kind of a point. So this is families, seniors, and health. And if you would click on each of these individuals, you'd see their bios. And the only person on the seniors or family, seniors, and health committee that has a healthcare background is Senator Lewis. Senator Lewis is a nurse by training. She's our first nurse to serve in the Senate, but she's the only one with a health background. The rest of these folks, Senator Moon, he did work in marketing for Mercy Hospital. Senator Nirenberg, she is actually married to a nurse practitioner. But Senator Hudson, he's a pastor. Senator Carter, she has an interest in education. So all of these folks here, there's not much healthcare background. So this is the importance of advocacy and why it's important for healthcare leaders to go and speak to their legislators, because these folks, they might not know the ins and outs of this. 340B is a complicated topic. And if you know, I guarantee you probably learned more on this call than a lot of these committee members had coming into this committee before that hearing. And so, it's important to educate our legislators on the ins and outs and the realities of how these bills potentially affect you, affect your practice, affect your organization, and how they correspond to the larger healthcare community. So it's one of the reasons it is good to go and meet your legislators and talk to them about the specific bills. So I wanted to show you the House website as well. So again, this is their brand new website. I sometimes get a little lost in it since they did just totally revamp it this year. But you search for legislation up here. I'm going to show you HB 825. This is a bill that has a hearing this week. So it'll take you there, you click on it, and then so you can tell that the web pages are set up very differently. This is the telehealth bill, you can find the bill summary over on this page. And so it opened into a new tab. It will also give you the full bill here, full bill text there. This one's another short one. It's only 2 pages. Anything that's highlighted or that's darker text, that's what's changed in the statute language. So this is the change that they're actually putting into statute there and there. So that shows you where the differences are. And then you can see that there, what committee that it was sent to, and you'll see here that there is a place where you can find the information on the upcoming hearing. So this one, you'll see it has a hearing on the 4th, which is Tuesday, in House Hearing Room 6. You can, one of the big differences between the House and the Senate is that you can submit testimony online on the House website. So you cannot do that with the Senate. You can do that with the House. So you can submit, if you click that button, it would take you to be able to submit testimony. So these are the bills that are up in that committee. This is the telehealth bill. This is a companion bill. Stennett is a Republican. Mansur is a Democrat. They both have mirroring bills, so they're doing the hearing at the same time. You can pick how you want to testify, so as an individual or if you're representing your organization. Support, oppose, so we are in support of this. We can enter our testimony here, and then it can say, you know, if I only want to submit my testimony if you're unable to attend. Same thing here. You put your information in, gives you a checkbox, you hit submit. It will be sent to your email to confirm that, and you can submit testimony that way. We always suggest coming to the Capitol instead of just submitting online. However, we do know with healthcare providers, with your schedules, it sometimes is difficult to be able to get away to attend hearings. We typically, legally, they only have to give notification within 24 hours of the hearing. They'll sometimes do that for bills that are a bit more controversial. Usually, we'll have a bit longer than that. Through the different folks who are working in the Capitol, they get an idea of when bills are coming up. But typically on Thursdays afternoons is when the committee lists for the week are released. So we found this out for sure today that this is going to be heard in the committee next week. I wanted to show you real quick how you can listen in also on the committees. So if you click at the top, the hearings list, it'll show you all of the upcoming hearings. Here is the health and mental health. So they have a hearing on Monday as well. Nothing's assigned to it. So you just got to double check that. They are all assigned here on the Tuesday hearing. And you'll see all of the bills. If you want to listen in, you click on this little live feed here. It will take you to, at the time, so at noon, you click on that and a video will pop up and you'll be able to watch the hearing. In the House, it is a video feed. In the Senate, it is audio only. So the one thing to remember, though, is the legislature very rarely is on time. So if you show up at noon and turn this on and there's nothing on your screen, don't panic. Sometimes they get late coming out during session, so they're out on the floor. They usually go in at 10, so they try to be done by noon for all the noon hearings, but if they're not, they sometimes do run over. So if you go on right at noon, nothing's on, just wait. They will come on eventually, and you can see, if you're curious if they're still on the floor. Oh, we're going to try and get back here. Well, maybe not. If you go to the home page again, it will show you what current action is going on the House floor. If there's still activity. Well, okay, house.mo.gov. Let's see, there we go. Apparently the state's website's wanting to be cranky this morning. So if you go there, it will show you in the corner what activity is going on currently on the floor. If there's still activity showing there, then you'll know that the committee is going to be a little bit late. Here we go. So it would be right here. They'll also show you any hearings that are currently in progress, so you'll be able to click on that. That's another easy way to get to it. That's actually a new thing that they've added this year. And then lastly, I want to show you on our website an easy way to track the bills. If you go to our advocacy and policy, you'll see our policy agenda and then all of the bills that we're currently tracking. This is through a program that we subscribe to. that allows folks to be able to track. You can sign up for a free account if you want, and you can track the bills yourself too. So let me go back to my presentation here. Just to wrap up today, I wanted to give you a heads up about our Rural Health Day, which is scheduled for February 25th. And we are really excited about this day. We have a number of partners who are joining us for the event that day. So it's kind of two parts. One, it's going to be an advocacy day. We want partner agencies to show up, and we'll have packets ready to go and talk to legislators about the legislative priorities of the organization and your organization. And then on the third floor rotunda, we will have 6 booths set up. We are very excited about the folks who will be presenting and giving information out on their rural programs. So our organization, MARC, Missouri Association of Rural Health Clinics, will be there. The MU Office of Hope will be there with all of their programs. Missouri Telehealth Network and the ECHOs will also be there. The Primary Care Association, the Missouri Hospital Association, and the Missouri Office of Rural Health will all be there that day, having booths with information. This is the first time in the over a decade that I've been working in the Missouri Capitol that I have seen a Rural Health Day. And so we're very excited to be kicking this off with all of our rural partners to get more information to the legislators about the important work that our different organizations are participating in. We also have our advocacy committee. And so the advocacy committee, they are meeting every other week during legislative session. So we just had a meeting. We're meeting on Monday mornings at 8 a.m. And trust me, as a non-morning person, that could be a little brutal sometimes, but we have a lot of really good information. We go more in depth on bills. If you want to get more involved with advocacy, no matter what your experience level is, you might not have any experience at all in advocacy. We have a wide ranging group there, from folks who don't know much to and just really want to get more educated and learn how to be involved, to other individuals who've been doing this for decades, way longer than I have, who join us on those calls as well to talk about the rural health priorities. And that's where we got both the priorities that we sent to our board, and then those individual bills that we're supporting this year went through our advocacy committee. And we are always looking to recruit more individuals to that. So if you are interested in that, please feel free to drop me an email and I will get you signed up for that. And then lastly, we're working on part of all of our plans with these things. So the Rural Health Day, the Advocacy Committee, is to start building a rural advocacy network. So individuals who are interested in rural health policy and helping to get things changed for rural Missouri. And so this is the start of the planning on that. So trying to get more actively involved in that to really raise the profile of what's going on in rural Missouri, what's going on and what's of importance to the rural healthcare providers, as well as the folks who work in social determinants of health in Missouri. And so if you're interested, please let us know and we'll get you. So the best place to start with that is the Advocacy Committee. We are also updating our MRHA Connect platform. We are building out our advocacy portion on there and partner with the Missouri Foundation for Health and the Missouri Foundation for Health's Exemplary Advocates cohort. So there will be lots of changes coming up over the next couple of months. We're hoping for a full rollout of all of the new changes by the time their next legislative session starts. So look for more information there. And then this is my contact information. If anybody has any questions, if you're interested in joining Advocacy Committee, feel free to drop me an email. I know I have some committee members on the call currently, but I'm happy to answer any questions folks have as well.